All right, welcome everyone. My name is Mary Dorschink, and I'm the Director of the National Colorectal Cancer Roundtable. And we are pleased that all of you are here today to join us for our webinar on lessons learned from the C5 Coalition. We have a great lineup for you this morning, and I'm going to turn it over very quickly to our host, Lina Jandorf, Professor of Oncology Sciences at Mount Sinai. Lina? Lina, are you there? Apologies, everyone. I understand our host got disconnected, so they're calling back in. We really appreciate everyone's time today. I can go over some housekeeping with all of you while we wait for the presenters to join back in. So first off, really appreciate everyone taking the time to join. We have an excellent turnout today and want to make this your webinar. Because of the high number of attendees, we are muting all lines. So you can hear the audio, but unfortunately cannot ask questions verbally. Having said that, we very much want this to be your webinar. So please do use the Q&A feature to ask questions. We really want to make sure that you get what you need out of this. So we'll save some time at the end to answer questions, and then any questions we don't get to, we'll definitely try to respond to afterwards. And of course, you can always contact the presenters afterwards. A few other things. One is that we will be evaluating this webinar series. So after this webinar, we will be sending out a short link for all of you to fill out. If you could please watch for that and help us by just taking a few minutes to give us your feedback. We definitely take your feedback seriously and try to use it to improve future webinars. And then finally, we are recording this webinar and we'll make a replay available a few days after the webinar. So watch for that. You should have gotten slides in advance, and we can resend them afterwards just in case you registered late and didn't get the deck that we sent earlier. Are my colleagues from C5 back on?
We are.
Yes. Great.
Sorry about that.
Well, wonderful. Lina, I went over the housekeeping for everyone, so if you want to just go over the purpose of the webinar and some of the introductory slides, we'll go ahead and get going.
Great. So I don't exactly know where you start. I'll just do the first little bit. My name is Lina Jandorf. I'm a professor of oncology, of oncological science at the Icahn School of Medicine at Mount Sinai. I also serve on the steering committee of New York City's Colon Cancer Control Coalition, known as C5. As Mary said, we thank you for joining us today and making the time. Today's webinar will share with you some of the highlights from a new publication that profiles the work of C5, titled New York City-Wide Colon Cancer Control Coalition, a public health effort to increase colon cancer screening and address health disparities. The publication was commissioned by the NCCRT and was published on November 23rd in the journal Cancer. So during the webinar, you'll be hearing from myself and three of the other publication authors, including Dr. Steven Itzkowitz, C5 co-chair and professor of medicine and oncological sciences at the Icahn School of Medicine at Mount Sinai, Mari Carlesimo, C5 director and senior director of the Cancer Prevention Program at the New York City Department of Health and Mental Hygiene, and Katy Huang, C5 program manager. So I just want to go over that, a little bit of what our goal will be today before I turn the slides over to Dr. Itzkowitz. So again, as we said, we're going to go over the purpose of and the work of the C5, and we'll end with a brief period of questions and answers, which you guys can all type in on your webinar. The presenters, as we just mentioned, are noted here in the next slide. And of course, greetings from New York City, a beautiful picture of Central Park on a fall day. And a copy of the article itself and the free online access thanks to the American Cancer Society's work, if anybody wants to get a copy of that. So our presentation will really cover what we did, what we learned, and does it apply. And with that, I'm going to turn it over to Dr. Itzkowitz.
Hello, everyone. Thanks for joining us. So let me review with you what we did to establish the C5 Coalition. In 2003, the New York City colonoscopy screening rate was about 42%, and there was wide ethnic disparities. We'll show you a slide with that data in just a few minutes. The leadership in New York City, we're just waiting to try to advance the slide. It's not, maybe the, slide's not advancing.
Technology, huh?
With a little arrow next to it.
Yeah.
Here we go. Okay. So as I said, in 2003, the screening rate was about 42%. We're talking about colonoscopy screening rates. And at that time, the leadership in the New York City government made colon cancer screening a priority. Dr. Thomas Friedman was, at that time, the commissioner for the New York City Department of Health, and he received very strong support from Dr. Benjamin Chu, who at the time was the president of our public health system called the Health and Hospitals Corporation, or the HHC. At that time, many of you may recall, colonoscopy as a screening test was a relatively new modality because CMS agreed that Medicare would reimburse screening colonoscopies only in 2001. So this is about 2 years after that recommendation was made, and Dr. Friedman had the foresight to consider whether or not colonoscopy should be the preferred screening test above all other screening tests. In order to consider whether that would be wise, he convened an advisory panel to see whether or not that would be an advisable message, because he really wanted to get across a single, simple message of screening colonoscopy. So he convened an advisory panel which included Dr. Harold Friedman, who many of you know as the grandfather or pioneer for patient navigation, Dr. Sidney Winnower, and Dr. Thomas Weber. And after a lot of discussion and deliberation, New York City issued its own colon cancer screening guidelines that preferred colonoscopy, and we relied on fecal occult blood testing really only for those who wouldn't choose to do a colonoscopy, or in whom colonoscopy might be contraindicated for some reason. So that, at the time, was fairly unconventional, if you will, and kind of forward-thinking. But we, as a community here in New York, decided to disseminate this to the providers in the New York City area. In order to really get the work done, and as an outgrowth of the advisory panel's work and meetings, we launched what we now call the C5 Coalition, which is the Citywide Colon Cancer Control Coalition. So we first identified goals, which basically were not only to increase screening rates overall, but at the same time to try to eliminate disparities and inequities. And it's really important that what really helped us get this off the ground was having a convening entity. And really, it was the New York City Department of Health and Dr. Friedman's leadership at that time, and to this day, frankly, that has kept us on track and really been the glue that has kept us together. We identified certain core champions. Certainly the advisory panel were our initial champions, but pretty soon we got leaders to not only be part of the steering committee of C5, but also run some of our subcommittees, and we started to assign roles. And at the same time, we engaged a lot of stakeholders to help us really not only get this off the ground, but also keep it going. So we identified a lot of healthcare providers, both primary care, specialists, GI specialists, surgeons, gynecologists, anyone sort of in the front lines who might be interested in screening for colon cancer. We identified health plans, GHI, Aetna, MetroPlus, amongst others, professional associations. So the NYSGE, the New York Society for Gastrointestinal Endoscopy, ACOG, American College of Obstetrics and Gynecology. We really spread the word amongst the professional societies. We engaged advocacy and survivor organizations. The American Cancer Society has been crucial throughout for really helping us disseminate the message and organize a lot of meetings and get the word out as well. And then, of course, the help of the Health and Hospitals Corporation, where a lion's share of the actual screening was done. It was also very important along the way to have data. And when we started back in 2003, we relied a lot on data from the New York City Community Health Survey, and that survey has been instrumental all along in helping us monitor where our screening rates have been going. We also have looked at the New York State Cancer Registry as well. And our initial target back at 2003, when we were at 42%, was to see if we can try to get to 60% in 5 years, 60% by 2008. And what you'll see in a moment is we actually exceeded our goals and got there about 2 years early. And so we identified, again, what inequities we would like to see erased, and we focused initially on race and ethnicity, and we'll show you how we did that and what the results were. Today, one of the nagging inequities that still exists is the uninsured, and we'll talk a little bit about that as well. So this graph just shows us how what we did. We started off with 42% screening in 2003, and you can see the curve went up fairly rapidly, fairly quickly, and again we got 60% by 2006 and reached about 66% in 2008. And if you look over this whole period of time, this translates into about 872,000 people who received screening colonoscopies over that period of time in New York City. Next slide. So that's the overall rate, and this breaks it down by race and ethnicity, and you can see there were a lot of disparities and inequities when we first started, with whites being screened much more often than the other groups, Asians being screened the least. And in relatively short period of time, we really eliminated the racial and ethnic disparities, and certainly ever since 2009, and pretty much consistently ever since, we have not really seen very much in the way of racial or ethnic inequities. So I'm now going to turn the floor over to Mari Carlesimo from the New York City Department of Health, and she'll take over for the next several minutes.
Good afternoon, everyone. It's an honor to be talking about the C5 Coalition, and I wanted to take a minute and thank the National Colorectal Cancer Roundtable. They commissioned this study and have supported and guided us for many, many years, and so we are very appreciative of our partnership with the NCCRT and their leadership. We're going to talk about initiatives. So as Steve said, we got our efforts off the ground about 10 years ago or 12 years ago, so we obviously can't talk about everything that we've done for the last 12 years. So we're going to just talk about a few highlight initiatives, and right now I'm just going to say the categories of initiatives. So we focused on public education or media campaigns. For colon cancer screening, we've never had the dollars that, for example, tobacco has, so it's not big TV ads, but targeted, usually poster ads that run in subways and buses in neighborhoods where we are targeting disparities, usually. We had professional education campaigns, public health detailing, and other professional education. We had advocacy initiatives along the way. The American Cancer Society, who, as Steve said, has been a key player for us from the beginning, leadership in so many ways. And in advocacy, they really were our leader. And just to highlight one of the things that ACS did back in, I think, 2003, 2004, as Steve said, New York City issued guidelines preferring colonoscopy as the screening mode. CMS had just agreed that Medicare was going to cover it, And we needed to know, we didn't have the Affordable Care Act requiring this at the time, so we needed to know whether health plans would cover it. In New Jersey regulated that and mandated that health plans cover screening colonoscopy. In New York State, the road to that regulation was a little slow, and so ACS pulled together all the major health plans across the state and asked them to voluntarily agree to reimburse for screening colonoscopy, which they did. And ACS also said, we can do this two ways. We can continue to move for mandatory reimbursement, or we can do this jointly, and so they did agree to do it voluntarily. So it's just one example. ACS has just been key. Health systems initiatives, I'm going to talk about some of them right now, but we've been working with health systems in many ways for the last 10 years. And I think one of the main messages that we want to give here is it's not so much find resources and do something, but rather bring the big systems and the key players to the table and ask them to prioritize colon cancer screening and bring their resources to bear. And how can we encourage that? Last collaborations, obviously, the C5 Coalition is the hub around which all of our efforts have been working. Steve really talked about this. This is just our structure. We talked about it. The stakeholders are listed there. And what I would say is if you're going to form a coalition, and this work is going on all over the country for many reasons, not the least of which is the great 80 by 2018 campaign launched by the National Colorectal Cancer Roundtable, which is a goal of reaching 80% screening across the country. This is encouraging coalitions all across the country and a renewed focus on colon cancer screening all across the country. And again, hats off to the Roundtable for this leadership. I'll tell you, I was in Pennsylvania just a couple of weeks ago, and they formed a coalition and had a couple hundred people there to kick it off. Their subcommittees, they organized by health plans, community health centers, hospital systems. So you can do it in any way that really mirrors the work that you're doing. One of our key initiatives in New York City was our colonoscopy navigator program. Briefly, our model was to, we pay, it's based in endoscopy in hospitals, so not in primary care, but in endoscopy with the goal of improving colonoscopy adherence, obviously helping the patients complete the process. We pay hospitals for the cost of the salary of the navigator for 1 year, and we say to the hospital, we provide technical assistance and training, and we say we believe at the end of that year you're going to see improved colonoscopy adherence and patient satisfaction, and you will keep this navigator on board. It was implemented in 23 hospitals. 18 of the 23 continued with the program, so we were obviously happy with those results. An article was published, the site is there, which demonstrated the cost effectiveness of the program. Those pictures are our navigators who are very reflective of the communities they serve, and all of them, I think between them they speak like a dozen languages. All of them are bilingual and trilingual. That's a listing of the navigator programs throughout the city. And the last one noted is Mount Sinai's navigator program, which was an amazing effort, NCI funded, articles published, again, establishing and pioneering the notion that the model is cost effective for navigation for colon cancer screening in endoscopy. Anything else you want to say? This is a resource, it's just a shot of, we have a toolkit. There are resources all across the country for navigation, and I think one of the wonderful, again, side effects of our 80 by 18 initiative going on all over the country is there's really systematic sharing of the tools and resources that exist. Just very, very briefly, this topic could be a presentation in and of itself. Because New York City aggressively promoted colonoscopy screening, we started an initiative to focus on the quality of those screenings. With funding from the CDC and the New York State Department of Health, we partnered with the National Colonoscopy Registry, GI Quick, We gathered data through the GI Quick system at participating sites in New York City. We analyzed the data and benchmarked back to our sites, and we also did some additional quality improvement interventions. I'm very much shorthanding that. We can answer questions later if need be. As Steve said, we have targeted disparities all along. You saw the great slide showing the elimination of racial and ethnic screening disparities. I want to give a huge shout out to the Health and Hospitals Corporation. The Health and Hospitals Corporation serves 1.5 million patients. About 90+% of those patients are patients of color. As of a year or so ago, their clinical data, their screening rate was over 70%, CRC screening rate, 72%, I believe. We would not have eliminated the disparities that we did without the Health and Hospitals Corporation. Also, the navigation programs were very important in the city. As we eliminated some disparities, I think this is an important, but obvious point. If you close a gap, drill down and go to the next gap. So Asians took longer to catch up, so we looked at language spoken at home, and then we're also going to look at the uninsured. This is just a campaign. Initially, we were focusing African Americans and Hispanics. That shows you that's the campaign targeted them. Then we focused on Russian speakers and Chinese speakers. For the Russian-speaking community, we also did formal focus groups and provider education. And just, we don't have the data is preliminary and actually going to be used for separate publication, but so you know, in terms of language spoken at home, we call it, back in 2008, English and Spanish-speaking New Yorkers were screened at a significantly higher rate than Russian and Chinese speakers, but from 2011, 12, and 13, all those groups are screened on par. What's the disparity we're focusing on now for the uninsured? If you look at this slide, not surprisingly, if you have insurance, you're much more likely to be screened. That's the blue line than if you don't. There is a positive trend with the red line, with the uninsured. I want to give a shout out to the American Cancer Society for a fantastic program that they administered for about a decade in New York City, and they screened by colonoscopy, I think about 22,000 uninsured New Yorkers, and that's helping to close that gap, but it's still too big a gap. One more point on this is some people say to us, with the implementation of the Affordable Care Act, do you still need to worry about the uninsured? The answer is a resounding yes, and New York City estimates that about 350,000 undocumented immigrants continue to live in New York City. They are obviously a critical and vibrant part of our communities, and they are not covered by the Affordable Care Act. I'll just say briefly, again, hitting on the uninsured, and with the concept of bringing systems together, we have a project called the Community Cares Project. We bring together endoscopy centers that are doing free screenings for the uninsured with community health centers who have uninsured patients in their systems that need screening. New York State has a charity care requirement that requires endoscopy centers to provide these screenings. And more on that, we have amazing champions for this in New York City. I hear this around the country, gastroenterologists saying that they are willing to do free screenings, but having trouble organizing systems to get underserved patients to their doors. That's really what this initiative is about. And one of our great champions was Dr. Blair Lewis from Carnegie Hill Endoscopy. He's a medical director. And they're one of our initial sites along with Eastside Endoscopy. Shout out to both of them. And Blair will tell you, frankly, when he first learned about the charity care requirement, he was not happy about it, but ended up writing, co-authoring an editorial championing this initiative and saying how much it has added to the esprit de corps in his site, and in his words, reminding them why they became healthcare professionals. So thanks for that leadership. And then just to note, we are proud of our disparities work in New York City, and in the past year, the Journal of Clinical Oncology noted New York City's work, and also Harvard Business Review. The quotes are there. And so the next section is what did we learn, which was a big part of what the paper, or C5's paper, focused on. So one of the things we talk about in New York City, and again, this would apply anywhere, is what are our assets and are we leveraging them? So what are some of the things we look at? We've talked about this, our strong and really massive public hospital system. Have we engaged them? Yes, we have, is the answer there. Our incredible engagement from high-level experts, the high concentration of gastroenterologists, an incredibly strong partnership with the American Cancer Society. And you can see the assets there. In addition to assets, it's what opportunities are going on in the healthcare system and are we leveraging them? Payment system reform, value-based payment, quality improvement initiatives. I talked earlier about GI Quick, patient-centered medical homes, community health centers focusing on CRC screening and having to report CRC screening to the federal government. These are just examples of assets and opportunities, and the question is, are we leveraging them? Now I'm going to turn it back to Steve to continue talking about lessons that we learned.
Great. So we're almost done with the presentation. We'd love to hear from you on the line, but so we're still learning. Even though we've learned a lot, there's more to be done, and there are still some gaps and challenges. But one thing that we have learned is that collaboration is key. You really have to continuously find people to become engaged and can keep them engaged, and distribute the leadership. Get those who are engaged to really play some leadership roles in the organization, because then they have a sense of ownership. And try to identify high-level champions. We were lucky in New York City that we had the Commissioner of Health, we had the head of the Health and Hospitals Corporation, we had health plan leaders, we had academicians, we had a lot of people really at high level, so that the message really was not just coming from the grassroots, but also from the top. You have to continually identify the ongoing inequalities, and you saw what we did. Initially, we tackled ethnic and racial disparities, and when we saw the Chinese and Russian communities were lagging, we focused on them. Believe it or not, there was a period of time several years ago where women were getting screened less than men, and we even had a task force looking at why that might be, and we actually, ironically, found that a lot of the women who were not being screened actually had a primary care provider and had insurance. So, things that we were not expecting, but you have to continually try to identify those pockets of individuals who are not being screened. And then try to create synergies, like Mari said. Engage organizations that are interested in doing colon cancer screening, like some of the endoscopy centers or community health centers, and leverage them to help you. And we encourage everybody to steal shamelessly. There's an enormous number of resources now through the Roundtable and others. So many people are on board with the 80 by 18 campaign. You don't have to write your own materials. Borrow them. And then data. Data is key. How do you know what pockets you still have to target if you don't know the data that's coming from your community? So try to tap into sources that can help you come up with the data. And then the next slide, what we're still working on now is really still trying to leverage primary care. We're still trying to help the community health centers see what they can do with colon cancer screening and screening colonoscopies, engaging health plans. As Mari said, the uninsured still represents a significant problem. And frankly, we have focused so much in the last decade on colonoscopy that to some extent we've neglected FOBT and FIT, and we kind of feel now that perhaps we have to do a little catching up, because there are still some pockets even in our city where colonoscopy is still a little bit difficult to obtain, and so that's something that we haven't focused on, but we may in the future. And we also note that although we all want to reach 80% by 18, if you go back to the slides that we showed you, there was a bit of a plateau effect. Things were leveling off. So we really have to redouble our efforts in any way that we can with whatever screening tests. We obviously preferred colonoscopy and did a good job, but any kind of screening is really what's important to get us to 80%. So thank you so much for your attention, and I think we'll turn it over to to Lina? Are you going to?
And Mary.
And Mary. Okay, to moderate the questions.
Well, thank you, guys. That was just excellent, and I've heard some versions of this presentation before, but I never stop learning more every time I hear you guys present, so that was excellent. We have plenty of time for questions, so thank you so much for getting through that great material so quickly. And our first question is from Anikia, and a good question at that. How did you track your screening rates? Was there a centralized database?
Hi, this is Maury. That's a great question. So New York City Department of Health, this was actually an initiative of Dr. Tom Friedman when he came on board in 2002, administers its own community health survey, our own behavioral risk factor surveillance survey, basically. And there are about 9,000 respondents questioned every year. It's an annual survey, and that is how we track our screening rate.
And importantly, I think, just to add to what Mari just said, is because it's local, we can actually break it down by neighborhood.
Yeah, thanks for that, Nina. Yeah, because it's robust, it's a very large, the sample size citywide is large. So we can break down exactly what Lina said. So when we're looking at disparities, so for example, when we worked with the Russian community, we could break down by neighborhoods where were the screening rates low and layer over it census data as to high concentrations of Russian speakers, and it enabled us to target neighborhoods precisely.
Wonderful. So question here, during this period, was New York State one of the states funded by the CDC's CRCCP program? And I guess the part two of that question is, did you guys work with New York State on these efforts?
Yeah, they absolutely were and happily are again for the next 5-year cycle, and they are very, very close partners and advisors for New York City. And I neglected to mention some of the work with the Russian-speaking community was funded through that grant and by the state through the CDC's grant, and also I think I did say our colonoscopy quality initiative was funded through that same pot of money and also with state funding. So yeah, the state are very strong partners and guides.
Okay, great. And then a question about the leveling off. What do you attribute that to? Or the plateau, I guess.
No, I think we'll let Steve answer that one.
I'm not so sure. We've been scratching our heads about that, and I think a lot of environments in the country are noticing that. My take on this is that perhaps we've reached the low-hanging fruit, and there is still going to be a refractory segment of the population that don't want colonoscopy. They have insurance, they have a PCP, they have a referral. There's a lot of other barriers. There's psychological barriers. People don't want to miss work. Some of us have offered Saturday colonoscopy hours, but still there can be those barriers. And that's another reason why we're thinking again about non-colonoscopy screenings, whether they be FIT or, some newer tests. But at any rate, that I'm a gastroenterologist, and I would love everybody to get colonoscopies because I think it's the best test, but the data is the data. It's showing us that there's still going to be some people who won't go for colonoscopy.
Yeah, and I think that actually speaks to a comment that was made about the evidence of offering patient choice. Do you want to talk about choice at all in the C5 program?
I'll mention, this is Lina, I'll mention a little bit about that. I think, one of the real strengths of the program was having a single message. So to some extent, going back 10 years ago, having only colonoscopy as the message simplified it from the point of view of both patients and providers. I think it really is important now to start looking at patient preferences because as Sid Winter would say, the best test is the test that gets done. So I think we all need to really, as Steve just said, really consider alternative tests, particularly for those who are decidedly not going to have a colonoscopy.
Okay, great. Another comment from our friend Steve Kaplan. This is a very impressive effort. How did you get high-level leadership and funding as well as grassroots involvement? And then part two, what would another city need to do to replicate this success?
It's a little hard to say, perhaps, but again, I think having the Commissioner of Health and the head of the HHC was key, and then they were smart enough to bring some of the brightest minds. We were fortunate in a way to have some really, really dedicated and bright cancer prevention people in New York City. Harold Friedman, Sid Winnower. I mean, Sid was running the guidelines committees in those days and running the National Polyp Study. And I think one of the things that helped was we engaged a lot of gastroenterologists and academicians. This wasn't just a sort of a community, public health. We really got people who were interested in the science of this, interested in really making it a methodical effort. So I think if you can try to identify leaders not only in the community and the health plans and maybe even the business side of things, but also academicians, because I think that kind of keeps people on track. As academicians are used to thinking about data, they're used to thinking about deadlines and goals and that sort of thing.
I'm just going to, this is Maury, I'm just going to, I agree with everything Steve said, and also just, I do think there was an effort initially by Dr. Friedman to bring in leaders from the other sectors as well. So when you had health plans and primary care settings, et cetera, also prioritizing increasing screening and also showing a business case for it, that helped tremendously.
And if I could just push that question a bit further, because we know so many states are looking to establish coalitions, and New York is sort of the envy of everybody else. So what specific advice do you all have for those getting started and programs that may be thinking, that they don't quite have the level of funding support that New York City had?
Hey, Mary, this is Maury. So my view, I think our view here is the most significant work and progress that happened in New York City by far happened out in the health systems. It wasn't because New York City found funding for XYZ. There was grant funding. We used grant funding. It helps a lot when you're targeting subpopulations. I am not saying that is not important as well, but all of us can bring to the table the leaders in the different sectors, and what you're asking is that they use their existing resources and prioritize colon cancer screening. So we can all do that without acquiring millions of dollars to begin. I think you need a little bit of resources for a convening entity. If you want a coalition, the American Cancer Society is playing that role in a lot of places across the country, which is incredibly helpful, I think. So there's a little bit of resources there to be the glue holding things together. But the work of increasing screening, by and large, is in the existing systems, I believe.
Wonderful. Anyone else want to answer that question? What advice do you have for coalitions just getting started?
Yeah, I mean, I think another resource that all of the states have are the cancer plan committees. And I think, again, you have then a really, I mean, I can only speak from New York State's Cancer Coalition, but those are people who are committed to the issues around cancer across the continuum. And I suspect, again, because each state has one, that it's a good place to start from a state point of view with people who are really both academicians and clinicians, et cetera, who are really engaged in the process.
Wonderful. Steve, any comments before we move on to the next question?
No, I think that really covers it.
Great. So a question from our friend Felicia Dickey. For patients receiving colonoscopies through the Community Cares Project, how is follow-up assured for positive results? Who is responsible for treatment and ongoing care? How are costs covered?
Great question. So first of all, we are very fortunate in New York State to have emergency Medicaid that covers cancer treatment for the uninsured, including for the undocumented. So that is a large part of the answer to that question. In addition, again, in our very, very strong partnership with the New York State Department of Health, New York State runs a cancer services program which provides screening, colon, breast, and cervical cancer screening for the uninsured, and also follow-up treatment. And patients diagnosed through the Community Cares Project also qualify for treatment coverage through the state's cancer services program.
Yeah, I just want to add to that. I think it's an important part of the, the leadership both at the state and at the city level in when you bring a provider on board that he or she has to commit not just to doing the screening, but to ensuring the follow-up of the abnormals. And so that's part of, and it was part of the free colonoscopy program. For example, as Mount Sinai as a hospital, we had to commit to making sure that treatment was available for somebody with an abnormal finding. So I think it also goes into that initial contracting with providers that they agree to that. And given, that the vast majority of procedures that ended up in a polypectomy, there weren't that many cancers. So I think to some extent you have to reassure the hospital systems that this is not going to be very, a huge burden, that emergency Medicaid, at least in New York State, will come into play to get people to come on board and to really do the right thing, which is not just to screen, but to do the follow-up.
But I think perhaps the questioner is asking, so forget about cancer, if you find a polyp, an advanced polyp that needs a colonoscopy in 3 years, how are you assuring that the surveillance procedures are being done? I think it's a new program. We don't really have a 3-year interval yet. Right. But there is communication with the referring doctors. And I have to say, I know some of the doctors that are participating in this, and they're so into it. And their staff love it. At Carnegie Hill, Friday is their day for the if you will, the charity cases. I hate that term, frankly, but the community cares, and the staff, they love it. They really, it's a real team effort. I also should give a shout out to the City Council. The New York City Council, over many years, probably about a decade, literally allocated funds from the city budget for screening the uninsured, and they did this by giving the money to the American Cancer Society, and the ACS basically asked which institutions in the city would want to do basically discounted colonoscopies. They weren't really free colonoscopies, but they were heavily discounted. So we, for example, were one of the 12 or 15 sites that participated here at Mount Sinai, and we would get about $600 total to do a colonoscopy on an uninsured patient, and that money had to be shared between the pathology costs, the room fee, and the professional fee. I frankly did all of those colonoscopies and didn't take a professional fee because there was money that was needed for the room fee and any pathology costs. But the point I'm getting at is that the city really kind of put its money where its mouth was, and if you in your local environment have some contacts with city government and can try to impress upon them the important public health nature of colon cancer screening, perhaps you might be able to get some funding that way.
Wonderful. So we still have time for a few more questions if any folks have them. But on board, if you've got something complicated, I will offer up our friends at C5 if you want to contact them directly. And I'm also happy to share that the journal Cancer agreed to make this publication an open access publication, so you can access it through this link here. If you want to share this link with your colleagues, please do use this link to share. That helps the journal Cancer understand which it helps them track how where access is coming in for. So a few more questions. Thanks. One from June Hunter. This is challenging for states where Medicaid excludes undocumented individuals. Any advice to how to handle that?
Lobby with your government.
I agree with that, but also I think from the public good point of view, and this is something actually that Steve did initiate with myself before this all started, we actually engaged endoscopists and the hospital to perform free colonoscopies before there was funding for the uninsured, and at that point predominantly the undocumented, as part of public service. And I think when we started, we had 12 endoscopists who each agreed to do 1 colonoscopy per month. So it's, it wasn't a heavy hit on any one person. I think it was Kentucky did that, but also to engage your providers. So if there aren't state funds, I mean, obviously you're going to run into the problem of findings and follow-up. But I have to say, people go into healthcare. I mean, I think it's what Blair Lewis said. I mean, it reminds people of why they became healthcare providers. And I think engaging 1 or 2 champions, and we had in New York City, I think we had Steve and Sid Winnower, who were really the champions behind this and were able to say to their colleagues, this is the right thing to do.
I also don't like to rely on philanthropy dollars, but I know that there's many sites around the country that have also tried to leverage philanthropy dollars for screening uninsured, and I'm sure most people have thought of that and are even working on it, but sometimes that's like your main source of funding.
Yeah.
Mm-hmm. Yeah, and a lot of similar questions along these lines. I can send around, along with this replay, a replay of a webinar we hosted in August where we put the spotlight on 3 different programs where they had built good relationships between the community health center specialists and the hospitals to try to get care for those uninsured patients. And much like in New York City, the recipe was, having a finite ask, knowing exactly how many colonoscopies you needed so that you weren't, flooding those who are willing to help, much like Lina was just talking about, 1, 2 a month, having a clinical champion make the request, and then, again, just as we saw in New York, having really good care coordination, patient navigation, so that when those patients went through the system, everybody knew what the process was and everybody knew that the patient was going to show up well prepped. So I will send around a replay to that webinar along with this one after the call, because I think it's got some great information that enhances what we've learned from New York City today.
Yeah, and Mary, I just want to add to that, because I think, again, we're sometimes, I think, staying too focused on colonoscopy.
Yeah.
And so for those states that Medicaid is not available, we have alternative tests that are much less expensive. So going to a FIT test in the same manner that we've done things, particularly through the community health centers, can be very successful.
Yeah, absolutely. But one more second, again, too focused on colonoscopy, which we are. But I just want to say, with our endoscopy centers that are doing this community cares program and doing the screenings for free, 2 of them, Carnegie Hill Endoscopy and Eastside Endoscopy, are now doing 250 screenings a year for the uninsured. So they started off small, but they hired navigators to work with this population as well. So sometimes if you can get it started, it'll grow.
Great. So another question, did you deal with any political opposition to provided services to undocumented persons?
Not in New York City. Thank God.
I'm sure that's something that other states wrestle with, so we'll try to get some other advice about that. So, excuse me. Another question, can you say more about how the denominators were computed in the statistics on proportion of persons getting colonoscopy? How were biases in the survey sampling dealt with, and what's known about whether there are subpopulations that weren't reached?
So I definitely, I would talk to our Department of Epidemiology and give you more specific information than I can. It's weighted to the census data. So we sample, right? There's about 9,000 respondents, and it's then weighted to census, which is how we come up with our rates for screening and how we identify the various subpopulations. And I think the question is, well, so what's the subpopulation we're focusing on now? It's the uninsured.
Great, and we get questions a fair amount about the limitations of some of the major data sets that are out there, such as BRFSS and the National Health Interview Survey and UDS. And, I think as long as we have some sort of baseline, even if it's not perfect, as long as we disclose our limitations, what we want to see is upward trends. And so, you can drive yourself crazy trying to find, the perfect measure. But really, it's simply a tool to help us, hold ourselves accountable. So, I think to some extent, what New York did is perfect. Let's pick a measure and then let's track it and see what we can learn from what we're finding.
Yeah. Thanks, Mary. That's great.
Any other questions from participants? This has been a wonderful, rich discussion, so thanks to all of our presenters. Going once, going twice for questions, and I will use this time to advertise. Well, first say thank you to Steve and Mari and Lina, and Katy Huang was on as well as a resource, and the entire C5 coalition. We learn so much from all of you every time we're with you, and of course your dear colleagues Sid Winnower and Tom Weber and many, many others have just been fantastic to work with, so many thanks. And also thank you to the CDC providing funding for this webinar and also funding for the publication itself. And then finally, I want to advertise our next webinar, which will be in the new year, 2016, where we'll be getting an introduction to the CDC's CRCCP program, and Fei Huang, along with a few other presenters from CDC, will be able to give you an overview of that program and answer any questions that you have. So, again, Steve, Mari, Lina, this was absolutely fabulous. So many thanks for your help today, and for all of those of you who made the time to join us. Thank you very much. We really appreciate all your help and interest. Oh, one last question, and we have time to fit it in. What do you attribute the dip in Asian screening rates a few years ago?
Yeah, so it's a small sample size, really. So I think that it's really that it's
a measurement.
Yeah, it's a measurement issue. We could really remove people ask us. We probably should just remove that dot. It's a measurement issue more than reflective. If you look at the trend, it's really, I think the important thing is to look at the trend line.
Yeah. All right, well, wonderful. Well, just excellent job, everyone, and thanks to all of you who made the time to join us. We really appreciate it. We'll be sharing a replay of the webinar for any of your colleagues that missed us today, and hopefully we'll hear from all of you on the next webinar in January. Thanks, everyone.
Great. Thank you.
Bye.